A very good morning to all of you. I warmly welcome all of you to another lecture in our CPD webinar series. First of all, may the Almighty bless you all with the best of health, wealth, and prosperity. Wishing you all and your loved ones a very happy Pongal. Without further ado, I would like to bring to your attention to the housekeeping rules for our webinar. As usual, the webinar link will be available from 9 a.m. to 9:45 a.m. for all of you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCC PD guidelines. We have ensured these rules and regulations to improve and maintain the standards of the CPD programs conducted here at Shri. We thank you again for joining us every Sunday to improve your knowledge and improve your academic achievements in our avenue. I would also kindly ask you to mute your microphones and to switch off your videos during the webinar series so that there will be no interruptions. We will be having a Q&A sessions at the end of the session. So please kindly type in any of your queries in our chat box, which will be open for all of you. Today, we have a very interesting topic, which is a much needed thing that we need to update our knowledge on. It is on Guillain-Barré syndrome, the 10-step approach. To bring to you today's very interesting topic is none other than our Dr. Anuruddha Padeniya. I am pretty sure I do not need to give you any special introduction, but let me talk to you a little bit about him. He is MBBS, DCH, and MD in pediatrics. He's the founder of the Good Intern program. He's currently a consultant pediatric neurologist attached to the Lady Ridgeway Hospital. He was the former academic head of the Department of Pediatrics at the Faculty of Medicine, University of Rajarata, and he's also a very prestigious recipient of the Eisenhower Fellow for the year 2012. So without further ado, I would like to give the floor to our distinguished lecturer today, Dr. Anuruddha Padeniya, talking to us about Guillain-Barré syndrome, the 10-step approach. Over to you, sir.
Thank you very much for the kind introduction. I think today we are going to discuss Guillain-Barré syndrome, which is a very important topic. And we will first join the slides. Today we are going to discuss the Guillain-Barré syndrome, and I had already received a lot of questions from you all, and it shows the interest. And the very day we uploaded the flyer, we got about 28 questions asking from various areas of the country. So therefore, what we did was, we wanted the Guillain-Barré syndrome to be simplified for you to understand. Most of the questions are basically questioning the basic essence of what is this Guillain-Barré and how you are going to work it out in the clinical setting. So that is your interest. So I think I should be privileged to obtain an article from Nature magazine, which gives us a 10-step approach for the Guillain-Barré. That will really make you very comfortable to organize your thoughts with regard to Guillain-Barré and to understand the basic principles behind the Guillain-Barré. And this is an educational lecture, so therefore I am trying to confine most of my material to evidence-based, and I will not go beyond the evidence-based to share my personal experience in the presentation. After in the Q&A session, I will be able to share my personal experience on Guillain-Barré. So I think before we coming to the 10-step approach, it is time for us to just to understand what this Guillain-Barré and all about it. And this lecture will basically cover a basis of history of the Guillain-Barré. And then Guillain-Barré always tied up with a lot of variants. And there will be a lot of confusion which might be tied up because of this explaining and understanding these variants of Guillain-Barré, which are not true typical Guillain-Barré. And then we will touch the 10-step approach for our practical reason. You can see in this video, and when we have the neurons, and all these neurons are transferring through their axons, and axons are covered with myelin. That is the basic knowledge that you have. So therefore, in a axon and then the myelin, both are very important to transfer the neurological material in electrical manner through the neurons. So we'll see how we are going to touch this approach. So history of Guillain-Barré, actually the Randry in 1959 actually has explained about this some features of Guillain-Barré, but he had missed the eriplexic feature. And therefore, they had the opportunity of Guillain-Barré and Stroll in 1916 to talk about and to coin this term of Guillain-Barré syndrome. For some reason, the Stroll's name had dropped, but now we are calling Guillain-Barré. So Guillain-Barré means there are two names of people rather than fundamental pathophysiological explanation. And we'll see. Now, still the Guillain-Barré is coming as a syndrome. So therefore, we know the basis of a syndrome is not an etiology, but it's a collection of signs and symptoms. But here, of course, not only the signs and symptoms, also it is coupled up with some other investigations as well. So all these features are lumped together to call it a Guillain-Barré syndrome, but it doesn't explain the underlying cause. Or etiological basis is not clearly explained. Basically, we are touching evidence-based approach in Guillain-Barré syndrome. So what is Guillain-Barré? It is simply to explain, it's an immune-mediated polyradicular neuropathy. So it's radicular part as well as the neural part is involved, and poly means a lot of neurons are, a lot of nerves are involved in this process. And the process is, though the pathophysiology is based on the immune mediated. We'll see what this immune mediation is. And that is the most common cause of acute flaccid paralysis, as you all know, especially after elimination of polio. This is basically leading in the field of acute flaccid paralysis. And globally, there are various incidents that have been reported, but for your purposes, it is 1 to 2% per 100,000 person years is what is ultimately published in late articles in 2019, 20, and 21. Annually, there are 100,000 cases are being reported worldwide, and you can see all over the world, it is not confined to one territory. Almost all the continents are involved, and different associations are being listed here. And you can see the types and the variants and those things vary, but it is a global condition all over the world. And coming down to the epidemiology, it's geographically and seasonal variations. It covers all seasons actually, and slightly more prevalence in the males. It's 1.5 like in most of the publications. And the Guillain-Barré incidence increase with age. However, it occurs in all age groups. And typical Guillain-Barré is one condition that we have to learn first, and later on we learn about the GBS variants and how what is the basis of this Guillain-Barré variant classification. Usually they come with lower limb issues. They come with that they find it difficult to walk, and they have various complaints, paresthesia on the lower limbs. And when they come, we will first touch the typical Guillain-Barré features. They present with symmetrical weakness. These are very important, because if it is asymmetrical, there are various other differential diagnoses will come in, and symmetrical weakness of the body. So it is mainly weakness means it's motor, and also it will touch up with or coupled up with sensory signs. Maybe sometimes it comes at the very early stages, and usually starts with the legs, and it slowly progresses upwards. So when it is starting from the legs, you know, the lumbar and the sacral nerves will get affected. When it goes up there, the thoracic nerves will get affected, and the thoracic respiration will get affected. And when it goes up to that level, then we have only the diaphragmatic breathing. Then it goes to the upper limbs, and then once it goes up beyond the cervical levels, the diaphragmatic breathing also will get affected, and then it will go up to the cranial nerves. So it's ascending slowly or maybe faster, and we see the temporal features of that. Usually it is acute or subacute, and the maximum disability or the progression goes up to 2 weeks. And if you have gone up to 2 weeks, then it will be plateau for people. According to the literature, it can be for days or weeks, or sometimes for months. It will plateau at that level of progressed disability or the weakness of the body. Usually by 6 months of age, 80% of them will be able to walk back independently, which means it's complete resolution in 80% of the patients. That's a good news. However, 20% will lead to the respiratory failure, and usually the mortality is links up with autonomic involvement. I have been talking to you about the motor involvement, then the sensory involvement, and the cranial nerve involvement. Now here is the autonomic. When the autonomic system is affected, usually it's around less than 10%, and that will have a lot of autonomic fluctuations in the heart and the autonomic systems, and that will basically leads for your mortality. The typical Guillain-Barré has several subtypes according to, especially with the invention of this neurophysiological diagnosis. They will see whether it is the effect on the myelin or the axon. So depending on that, they will classify into various subtypes. Also, the same subtypes will involve whether it is only motor involved or the sensory involved. AIDP, we'll see what AIDP, then AMAN and AMSAN. These terms, how do they stand for? Usually it is a monophasic disease. However, there are two other things that you need to consider. When you treat, especially when you treat IVIG within 2 days, the fast introduction of IVIG, there can be treatment-related fluctuations. So therefore, you might think it's not monophasic. At the same time, there's a rare chance of relapsing, and because of that, but majority will behave like monophasic disease. Autonomic dysfunctions is a serious thing, and it can have impact on the heart rate, and the blood pressures can vary, and very little that you can do about, even in the best ICU setting with the intensivist and most sophisticated facilities. Still, we might be able to, it may be very difficult for us to handle these autonomic dysfunctions and ultimately lead to mortality at the end of the day. At the same time, the other autonomic features, it can happen in all the urinary bladder and constipation, and those things will not account for various types of the mortality. But the most important thing is the autonomic inputs on the heart. Sensory symptoms also vary. It can be various types of paresthesias, and maybe in the distal limbs, we'll talk in time. And it can last for long, and sometimes even once you completely recover from the disease, sometimes these kind of sensory symptoms might persist. And proximal sensory changes are usually uncommon. Usually the sensory involvement is in the peripheral region. And some patients complain of pain, and it's my lower back or maybe a hip region pain. It is very common, and also it can have impact that might precede the weakness, and sometimes we might misdiagnose what this is all about. Recently also I had a patient who just came with this pain complaints, and the pain is so severe, I thought it was myositis, and we did CPKs, and ultimately, even to test, even when I touched the patient, child was shouting, and to do the proper examination was in trouble. But however, with the neurophysiological and other process of diagnosis, it was found to be Guillain-Barré. We'll talk about the pathophysiology. To be honest, according to 2019 Nature article, and then in 2021, the Lancet articles, they claim that the real autoimmune basis is not fully understood, what they say, but there are various theories presented, there are various publications to support various theories. However, it is the trivial infection triggers the humoral immune response. So because of that, there will be antibody production. So how the antibody production happens? Because of molecular mimicry. What do you mean by that? The antibodies produced against the organism might go and hit the nervous system. That is what is called so-called molecular mimicry. In this case, the specific gangliosides, which are around the neurons, might cross-react, and ultimately the antibodies produced against these organisms will go and interrupt the functioning of either myelin or the axonal work of the neuron. And it is happening through the complement activation, and then subsequently activating the macrophages and going and attacking the Schwann cells and the terminal axons. So therefore, it is very important that whatever the immune mechanism, ultimately the target organ is either the axon itself or the cover. So we call it myelin, either of these parties. So depending on this, the pathophysiology might, or the clinical features and the prognosis might vary. You can see here just a cartoon-wise explanation to you. In the upper picture, you can see through the humoral mechanisms, antibodies are produced, and these antibodies are going and binding to the myelin. And through that, the complements are getting activated, and then the nerve injury, nerve in the sense nerve covers, and the macrophages will come and do the maximum harm there. So therefore, when the myelin is lost, obviously, you know, myelin is always facilitating the nerves to transfer the message faster. So that part will get affected. So therefore, there will be delay in transferring the message through those affected nerves with the damaged myelin. At the same time, the second picture you can see, instead of attacking the myelin, they will directly attack the axon itself. You can see the antibodies are going and harming that. And then this GM1, GD1A, like say the gangliosides are coming into place because their wall is consisting of gangliosides. So therefore, the antibodies can be identified as anti-ganglioside antibodies. In the Miller-Fisher variant, there's a typical ganglioside GQ1B is being used to diagnose, because 90% of the Miller-Fisher will have this GQ1B sensitivity. And you can see the effect, that area is very exon terminals are being affected in the Miller-Fisher variant. So this is still we are in the pathophysiology. Just to explain, it's the immune mediated, not fully understood, and positive through the antibodies in the humoral mechanism and by complement activation and through the macrophages. An attack will be either on the myelin or on the axon, or maybe the terminus of axon, and depending on that, the clinical picture and the prognosis will vary. Having understood that, just another pictorial presentation of the same concept I want to explain. Now, how are you going to identify this is what is important. Now, infection and molecular mimicry, I told you what will happen: infection, then the antibody production, and then the nerve damage. So that is what is happening, just a pictorial representation of the same concept just to highlight you. You can see now in the upper picture, you can see when the myelin is there, it's with the transmission of the message is very fast. But here, of course, it's very slow and might get terminated at halfway through. So therefore, the terminal end will not get the message, and ultimately there will be weakness. And at the same time, the sensory system will have a lot of paresthesia or various types of sensory symptoms. So this is what is happening. So this is basically explaining when the myelin is affected. So the first picture, actually, I'm again explaining in a cartoonized manner. Then if the axons are damaged, you can see if you have 1,000 axons in one nerve, say about 500 axons are damaged. Now what will happen is the rest of the axons will have to transfer all the messages. So therefore, again, you will have weakness. So that is axonal degeneration, because you can have the damage either on the myelin and or on the axons. That is the basis of my lecture. That is why I'm stressing again and again on this, the same point. So this is the putting both things together. You can see the upper picture is explaining that myelin is completely damaged. And here, of course, you can see that the myelin is intact, but the axons are getting damaged. So how do they get reflected on the neurophysiological findings? We will come to that. So how are you going to identify this? Is basically through the, it is the extension of the neural examination. So we do the clinical examination of the nervous system, and when we can't certain things find, we use the electrical activity using this neurophysiological studies, we call it, and then to see what exactly had happened to the nerves going up to the level of histological level. So we use techniques to transfer the electric activity. So thereby you classify this AIDP, AMAN, and AMSAN. Now, obviously, AIDP is this acute demyelinating intermittent polyneuropathy. So obviously, it is demyelinating. So the effect is on the myelin sheets. And these two types are basically axonal damage, AMAN and AMSAN. So AMAN is completely motor, and AMSAN is motor and sensory both. But it is basically on the axonal damage has taken place. So that is how they classify. So AIDP on the myelin damage, and AMSAN and AMAN is for axonal damage. So obviously, when there is axonal damage, you know the regeneration takes place in time. So therefore, AMAN and AMSAN will have a relatively worse prognosis compared to the AIDP type. So nerve conduction, how do they identify this? Obviously, when the myelin is not there, what will happen or get in damage? This when you give the stimulus at some point to activate the muscle, it will take, or the nerve release. Now, when you give the current somewhere here and to receiving end here, this duration is, there is a normal duration expected, and that duration will be lengthened or will be delayed. So that is how you think that the myelin sheath is getting has already got affected in this nerve, what we are going to test. But if it is an axonal damage, what will happen is, instead of, if we have 1,000 new axons working here, if the 500 axons are damaged, the rest 500 or half of the 50% of the axons will be working. So therefore, what will happen is the amplitude of the activity will come down. So if the amplitude has gone down, then you know that is either AMAN or AMSAN type. But if the latency has gone beyond the limit or got delayed, then we know that it is demyelinating type. So it is AIDP type. So this is the proximal stimulation, and this is the recording at the distal end, and this distance is calculated by the computer, and these graphs are being drawn. I think I am clear about it. So this is what is the neurophysiological diagnosis, what they do. So again, to emphasize, if there's a myelin damage, there will be delay. So that will be read by this, the expected time period to transfer this message will be delayed. But if there's axonal damage, what will happen is the amplitude will come down because some of the axons are already damaged. So going by that, this is the type of report that you may be receiving, and then you might hereafter you might understand this is the AMAN type, the amplitude has gone down, and the AIDP type, the duration has extended for a delay. So that is how you diagnose. At the same time, the Guillain-Barré, another important thing is the sural nerve is usually spared. So that is one important thing, that how a neurophysiologically they will be confident to say that it is possibly we are in the territory of Guillain-Barré. But obviously, at the very beginning, what they do is the neurophysiologist, just to see whether you are in the Guillain-Barré involvement, you do the F waves and H reflexes. So what actually happens with the F waves and H reflexes is they do the entire, they release a stimulation and read it through the, it goes up to the spinal cord, and then it comes back to the muscle. So if the entire pathway is working, that will be read through the F waves and H waves. And then, so then they know that there is a trouble here, that nerve receiving and then ultimately going down to the muscle, the entire pathway is in trouble. So once you identify that, that's a kind of a screening test. Then what you do is, then they will differentiate whether it's a demyelinating type or axonal type based on the findings, right? So AMAN type, obviously, now you know it is a axonal damage, and you can say acute motor axonal neuropathy. So therefore, it is axonal damage, not the myelin part. So therefore, the prognosis is expected to be bad, and it is motor, and it is purely motor, and usually common in summer, and it had been reported in certain parts of China. And the nerve conduction will have the amplitude reduced CMAP amplitudes, and the latencies will be normal, and the conduction velocities will be normal, and usually normal sensory studies. So when you put all these findings together, then the neurophysiological diagnosis is, it is the typical Guillain-Barré AMAN type. Then we have to prognosticate accordingly. AMSAN type, where the motor and sensory both affected. So obviously, again, it is axonal damage. So therefore, the amplitude should go down, and the duration, or there won't be delay of transfer. And this is again geographically or epidemiologically explained in various territories. Unfortunately, the cranial nerves and them, it is difficult to do the neurophysiological studies. So always they go by the clinical findings rather than going and doing neurophysiological. It's not hardly possible, especially in the children, to do neurophysiological findings in the cranial nerves. And coming down to the Miller-Fisher, as I told you earlier, GQ1B antibodies at the terminal axons, axon terminals, are being tied up, and it's 90% of the Miller-Fisher will have GQ1B. So that is an alternative way, rather than doing neurophysiological studies, to kind of conclude or diagnose Miller-Fisher. All these are syndromes. So we are gathering various kind of investigations, clinical features together in order to conclude it is Miller-Fisher syndrome or Miller-Fisher variant of Guillain-Barré syndrome. Then this so-called Bickerstaff encephalitis, it is again the, now Miller-Fisher, what are the features of Miller-Fisher? We'll go through first. The Miller-Fisher is basically, there are three things: ophthalmoplegia, ataxia, and areflexia. These are the three features. And basically it is more or less peripheral nerve system involvement, the fissure. But when the brain itself, the central nervous system is affected, leading to cerebral signs of these features with CNS involvement, then it goes down to the you have your sensorium going down, or your consciousness will get affected. At the same time, the pyramidal signs will get affected. That is why Bickerstaff brainstem encephalitis. So it is again currently listed under the Guillain-Barré syndrome. So it is a Miller, I will go into details in time. So the Miller-Fisher is simply, we can call it more in favor of peripheral nervous system from the cranial nerves. But when the central nervous system is much more involved, then you call it a Bickerstaff brainstem encephalitis. But both of them are going hand in hand, whereas the Bickerstaff is the worst scenario, since the sensorium and the pyramidal signs are also affected. You can see the differentials also vary according to the condition. Right. Telling all this stuff, I think it is time for us to develop an approach. That is what is most important for a clinician, especially the listeners of today. This is educational lecture. Basically, how we are going to develop approach to Guillain-Barré syndrome. Now you have an idea what Guillain-Barré syndrome is. It's an immune-mediated system. Immune system basically affecting either myelin or axons. And there are a lot of variants, whether they are affecting the lower limbs, or whether it is going up to the upper limbs, or if it is the cranial nerves, or to that extent the Miller-Fisher is in the cranial. And if the sensorium affected and the pyramidal signs are affected, then there is this so-called, it is going up to the encephalitis, because the Guillain-Barré per se has no CNS involvement initially. So both, it is a spectrum for you. So there can be a lot of confusion coming up. So how we are going to work it out? So to avoid your confusion with this background, we would like to come up to this, to develop an approach to Guillain-Barré syndrome. Luckily, there was a consensus statement on the Nature magazine, published in prestigious Nature journal, had published this in 2019. And this, we have to honor these leading Guillain-Barré, or the neurologists, who had sit together and simplified the Guillain-Barré approach to 10 steps. So that is why I listed my article, my presentation also, Guillain-Barré syndrome in 10-step approach, which will basically make your thoughts much more comfortable and understandable in the process. So we'll see what these 10 steps are all together. So they have basically lumped all these 10 steps together in one slide. You can see first 2 steps are on the basis of diagnosis, actually, when to suspect Guillain-Barré and how to diagnose Guillain-Barré. That is the part of diagnosis. Then you go into the management part. So then whether you are going to manage the patient at home, whether you are going to be inward or in a high dependency or ICU, that decision had to be made. So how are you going to make that decision is the third part. Fourth part is whether we are going to treat this patient or not, because sometimes the Guillain-Barré may be left while observing that without aggressive treatment to that. So how are you going to make that decision, whether we are going to treat them or not, and with what medications, and how we are going to treat is the important thing. Fifth point is how we are going to select the treatment option. And the sixth thing is how we are going to monitoring while at the initial phase, then at the treatment phase, and then afterwards. Then how we are going to, number 7 is how we are going to identify the early complications, and then the clinical progression is number 8. Lastly, the long-term care, predicting the outcome of the prognosis had to be touched up, and the long-term rehabilitation and the 10 step number 10. So how are you going to work it out? We'll touch these 10 steps, and that will be the end of this lecture. Slide stuck, Right. First step, when to suspect is very important. Now, how are you going to suspect whether you are dealing with the Guillain-Barré or not? What is your experience? We'll see. Now, first thing is, usually there are 4 elements listed here. There will be clinical signs, rapidly progressive weakness of the bilateral limbs, or they call it bilateral or symmetrical. And then it will be coupled up with sensory features in the periphery, I told you, rather than the proximal regions. And then when you take your knee hammer, you will be able to detect either areflexia or diminished reflex, you call it hyporeflexia. At the same time, it is time for you to see whether the cranial nerves and the bulbar features are there or not. It's very crucial. We will understand in time and to see. At the same time, since there are variants like Miller fissure, it is ophthalmoplegia and ataxia also had to be visited. Now, when these features are presented in a patient, obviously we will think whether we are dealing with Guillain-Barré or not. Now, how are you going to work it out on this topic? Is the typical Guillain-Barré versus variant. So first we will touch the typical Guillain-Barré. So obviously, as I told you, it's a symmetrical weakness starting from the lower limbs, and it will rapidly progressive upwards. And in absence of CNS involvement, I stress the point that in the bigger staff involvement, that is the only condition we have the CNS involvement. Here, the Guillain-Barré is a peripheral nervous system problem. I told you it is a polyradiculoneuropathy. It can affect the motor, sensory, and the cranial nerves and the autonomic system, but the CNS is spared. But in the typical Guillain-Barré, so CNS is spared. And there will be absent or reduced reflexer depending on how you are going to examine the patient. And then you will have this autonomy as autonomic system. So very importantly, there are 5 features that you are supposed to touch. That whether how is the blood pressure, how is the heart rate fluctuation, and where the pupillary reactions, all these things you are competent with. Then to see whether there are bowel bladder involvement. And at the same time, I told you about the pain and other paresthesia activities that can be under 3 headings. It can be muscular pain, it can be radicular pain, or it can be neuropathic pain. So when these features are presented in a patient, obviously we will suspect whether we are dealing with Guillain-Barré or not, because it's a crucial diagnosis. If you miss the diagnosis, they might ultimately had to compromise with their life. So, and you will get a very bad reputation. So with these features, you have to suspect. How then the disease progress? That is the other point that you will get a clue. This is acute or subacute. It's not a chronic condition. And then the disability fast growing within the first 2 weeks. That's another important thing. If you come out the patient with 2 months, 5 months, that is not you are dealing with Guillain-Barré. And very importantly, if the progression is so rapid, then if you get a patient within first 24 hours, you have to think about the alternative diagnosis, infections or strokes and other conditions rather than thinking about the Guillain-Barré, because it phases out over 2 weeks. And if the progression is going beyond 4 weeks, again, you may be not dealing with Guillain-Barré. It's very unlikely. You might have to think about alternative diagnosis in that way. So therefore, very importantly, acute or subacute onset and grows up or getting progress within the first 2 weeks is what is important, not less than 24 hours or more than 4 weeks. This is some kind of pictorial presentation of the same concept. You can see it should usually the progress is now it is 4 weeks. It's slowly growing up, and if it won't grow, and then you go into a plateau, and then you start recovering depending on the period. So therefore, you have and if it is within first 24 hours something, you have to think alternative diagnosis, and this antibody formation start to ganglioside. So therefore, the antibodies and other elements will not be positive at this phase. You might even the CSF findings, the nerve conduction findings may be negative, or we might get misguided at the very first week because they are still in the development phase, and subsequently we'll get slowly those parameters getting positive. So the progression will go, and then the plateau phase, then the recovery phase, and with or without disability, depending on the condition that you are dealing with. So atypical Guillain-Barré is the weakness and the sensory signs may be there, may be asymmetrical. Now I am confusing you. I told you symmetrical. Now it is asymmetrical. Yes, that is why I call it atypical Guillain-Barré. And predominantly that is in the proximal or distal. So it's the opposite what I am talking now. And sometimes it's maybe in the arms, not in the legs, and or it may be simultaneous to all 4 limbs. So basically confusing the atypical Guillain-Barré, will get a lot of differentials coming in. Especially in the children, as you know, we have to have a extra cautious on the diagnosis because they find it poorly localized to the pain, and they will come with refuse to bear weight and walk, and we might miss, and they might be irritable, not allowed to examine, and there can be features of meningismus-like features to misguide us, and there will be unsteady gait for us to think about other differentials rather than the Guillain-Barré. That is why diagnosing Guillain-Barré in children, we have to be extra cautious, and we have to have high degree of suspicion in order to not to miss this Guillain-Barré. That is the worldwide trend and the position. You can see the Guillain-Barré variants have been nicely put together. There are how many elements? There are 8 variants we are talking about. Now, the first thing is the pure motor is what we call it. We can call it the typical Guillain-Barré, which is standing on the second, and the classic sensorum motor is the most typical version actually. That is, we have the sensory motor and sometimes plus or minus autonomic features, and that is standing number 1. Then you can see these 3 if you take together, the lower limb involvement, and the 4th variant is actually upper limb, we can call it, though it is called pharyngeal, cervical and brachial. It is the upper limb mainly involved, but the term is pharyngeal, cervical and brachial. And then the 5th picture is basically reflecting the cranial nerve involvement. So therefore, they come with bilateral facial palsy with paresthesia. You can see this peripheral paresthesia is what is mostly represented rather than the proximal. So here it's the lower limbs, this is the upper limbs, and this is the cranial nerves. So those are the 3 variants. So now we have covered about 5 variants and the typical Guillain-Barré. Last 3 is you can have the pure sensory variant. At the same time, the last 2 are Miller-Fisher and the Bickerstaff. You can see the Miller-Fisher, the ophthalmoplegia, areflexia, and ataxia is the main features. These lines are actually representing the ataxic features. Down here, you can see the key. And here, the same features are there on the Bickerstaff, but they are more involved with the sensorium, or the CNS effect is there. At the same time, there can be pyramidal signs. So now you can see, now you might have the clarity in your mind, the Guillain-Barré syndrome, what is typical Guillain-Barré, and how the variants are being listed down the line. So now you may wonder whether why this kind of variations are put together as one entity called Guillain-Barré. Simple reason is the lumping is done based on the clinical features and the pathophysiological reasons. It's like, I would like to explain it like a cerebral palsy. When you have the hemiplegic cerebral palsy, when you have the diplegic cerebral palsy, when you have the quadriplegic cerebral palsy, when you have the athetoid cerebral palsy, when you have the mixed cerebral palsy, actually both are different diseases when the patient point of view and the management point of view for us. But because of the similar pathophysiology or the brain insult, we are putting all these cerebral palsy in one camp. But from a patient point of view, there are different diseases. The similar principle has been followed in the Guillain-Barré also, based on the pathophysiological and clinical findings they have put together. But obviously, you may get confused since all these things are put together. So actually, from the patient point of view, these are different diseases. And if you take Bickerstaff, brainstem encephalitis versus the classic sensomotor Guillain-Barré, maybe you may have completely opposite features where you will have to deal with. So Guillain-Barré variants, the basis of the Guillain-Barré, I told you, is subjected to debate. A lot of debate is going on whether we should be in the same camp or not, whether we have to consider these variants as different diseases is being a debate all the time at the level 4 discussion at the neurology field. And however, as they do not fulfill the diagnostic criteria of GBS. However, the basis of the current basis is they share the clinical or pathophysiological features of the Guillain-Barré spectrum. Now you can see I have listed here the Guillain-Barré rough frequencies. You might wonder whether 30% to 85% has no meaning, because I have listed there according to the publications. These are the variations that they have found, and depending on the continent and the country and the seasons and the geographical reasons and the infections, vaccines, all these things had given different types of Guillain-Barré, typical and the variants accordingly. You can see the classic Guillain-Barré is rapidly progressive symmetrical weakness of the sensory with the sensory signs and absent or reduced reflexes, and usually reaching the nadir at 2 weeks. So this is the typical one. We have been already, now you are fully aware. Then the pure motor is, it's purely motor weakness without the sensory signs. So it is also covering up a significant percentage. Then the paraparetic one, I told you that that is the lower limb version. I told you for your understanding purposes, it's restricted to the lower limbs. Then you have the upper limb variety, again much rarer than the lower limb variety, and that is affecting the upper limbs, but the pharyngeal and cervical part also being coupled up with. Then the bilateral facial, the cranial nerve version I have been telling, that is also rare variety, where you have bilateral facial weakness with paresthesia and reduced reflexes. Then the pure sensory version, it is confining to the motor part, is completely not there. Then the Miller-Fisher variant, I told you the 3 features: ophthalmoplegia, ataxia, and areflexia. And usually it is coupled up with the GQ1B antibodies in the 90% of them. And it is basically, we can call it another variant. Because staph encephalitis, I told you, it has all these 3 features of Miller-Fisher, plus the pyramidal signs and impaired consciousness, and often overlapping with the sensorometer Guillain-Barré. So now you are clear the typical Guillain-Barré and the variants, and you can see the available percentages, the epidemiological feature. That is also important to think whether it is a rare condition or a common condition. Then the other point, clinical clue that we can get is the preceding infection for Guillain-Barré. Usually we ask whether when a patient comes with this weakness, whether you had a respiratory or diarrheal or some kind of infection during the last few weeks. Usually according to literature and the publication, they say you have to go up to about 6 weeks to see this, and they have listed about 6 pathogens. You can see here, which have been tied up with Guillain-Barré syndrome, or maybe more than that. This is what had been documented, and the available evidence are available in this Nature article. Then they have linked up with the several vaccines, especially in 1976, the swine flu in influenza vaccine, and the influenza vaccine had been linked up with the Guillain-Barré syndrome. However, the surgery and malignancy have been in the listing when we were medical students, and then we have been listing them. But according to the latest literature, there are a lot of evidences rarely scarce with regard to surgery and malignancy. Now we are going to the second step. So first step is how to suspect the Guillain-Barré. Second step is how we are going to diagnose the Guillain-Barré syndrome. This is the most important thing. Obviously, the diagnostic criteria had to be developed. We'll talk about that in a moment. And Guillain-Barré, obviously, we have to have the history, examination, then the investigations, especially CSF and the electrophysiological studies. So we put these 4 together in order to get a proper diagnosis. So whether there is a clinical diagnostic criteria, to be honest, they haven't developed a clinical diagnostic criteria, but there had been the because we don't have a single biomarker to diagnose Guillain-Barré, to say that is Guillain-Barré. That is why we call it a syndrome, because we collect usually the syndrome, the understanding is the clinical features, but it is beyond clinical features. We get several investigation features also in order to do this syndromic diagnosis. Now, having said that, then we don't have a single biomarker. The diagnostic criteria were basically research-based. NINS and Brighton collaboration both were developed on the research base, not for the clinicals. But currently, in the absence of a clinical criteria guidelines, we used to usually the most of the clinicians, they recommend the NINS, modified NINS in 1990 is as the Guillain-Barré diagnostic criteria. We'll see what is this NINS is. The Brighton collaboration, also some research work they are using, but mainly clinical purposes, the modified NINS is being used. So NINS criteria, obviously you can see that there are features essentially should be there. Then there are features to strongly support. So obviously the essential features, obviously you can see the progressive bilateral weakness, the features I have been telling. And then the strongly support features are things that we can see. And then you have another conditions to cast doubt about the diagnosis. Basically exclusion criteria, we can call it inclusion and exclusion criteria, like, because it is a research-based guideline. You can see the progressive phase, if it goes beyond 4 weeks, less than 4 weeks, usually within 2 weeks, it's a supportive feature. And relative symmetry is important, and with the exception with these variants, we have to understand. and then the relatively mild symptoms in the sensory part, then the cranial nerve involvement, autonomic dysfunctions, muscular and radicular lumbar pain, and the CSF, when you have the proteins going up without the cells, we call it albumin cytoprotein dissociation. And then I will go into details in time. Then the electrophysiological diagnosis. When you have, these are the other features in the NINS listed where you have doubt, especially when you have increased number of mononuclear in the CSF, when you have more than 50 cells, then in the microliter, then you might suspect whether we are not dealing with Guillain-Barré, maybe some other diagnosis. Then when there is asymmetry, marked asymmetry, then you have to think about it. When there are bladder bowel dysfunctions, you think about transverse myelitis and various other diagnoses in place. And when the severe respiratory dysfunction limited to limb weakness at the onset, then again you think about various other diagnoses. Sensory sign limited to the weakness at the onset. Then I told you, if we have very fast progression within 24 hours, again, if there is fever at the onset, all these features basically direct us for other diagnoses. So these are features to cast the doubt on the diagnosis needs. And coming down to the CSF, we call it albuminocytological dissociation. And that is very important. What do you mean by that? There are two features. The cells are not going up, but the protein, you know, usually it is around 30 to 50, and the proteins are going up. You can see, as I told you, in the first week, it may be not that sensitive, but in the second week, third week, it is more sensitive because the cytoprotein dissociation is more apparent when time passes by. So therefore, if you are going to do the LP during, if you do the LP at the very first week, you might get a negative results, and then you might get more confusion with regard to Guillain-Barré diagnosis. And with that limitation had to be understood by, you should be aware of that limitation. The neurophysiological, I told you, the amplitude and the delays in the neurophysiological diagnosis process. So that is important for the subtyping. As I told you, it is AIDP type, AMAN type, or AMSAN type. How are we going to time the neurophysiological? We have to rush to the neurophysiological studies? As I told you, similar to the earlier CSF findings, it usually after 1 week is the best. And if you have a normal report, or we call it equivocal or inexcitable report, which can be in 1/3 anyway in the Guillain-Barré, and you can beat that by doing a neurophysiological study after 2 to 3 weeks. Since this is an invasive test and it's painful test for children, the timing is so important that we have to have the patients to time it and do the proper diagnosis. But 1/3 of the Guillain-Barré patients will not have the neurophysiological support for our diagnostic claim. Whether there is a place for MRI. Recently, there had been certain findings that the MRI is also showing some enhancement, you can see down there, but it's not a routine part of diagnostic evaluation. But if you do it for some reason, some neurologists or some radiologists, they commend this and they strongly suggest that the findings are not in favor of transverse myelitis, it's in favor of Guillain-Barré syndrome. I had that experience when we thought it's transverse myelitis, especially when they have the bladder bowel function affected. Then we think about sometimes when the child is much smaller, to get the sensory level and them is not, that's a struggle anyway. Then we might do MRI, not to lose anything. And there we find these findings. Recently, there had been trials and attempts made using ultrasound, because that is a non-invasive, low-cost mechanism to see whether the same enhancement of the MRI enhancement can be read by ultrasound. There had been success stories. So it will possibly come to light or to clinical practice in time. So now we are clear about the Guillain-Barré syndrome, the various types, the pure motor sensory mix, and then the lower limb, upper limb, and the cranial nerves, and the Miller-Fisher and the bigger stuff is very clear to you. Again, just to highlight, then depending on that, obviously, you will list down the differential diagnosis accordingly. You can have a look here, the various types of differential diagnosis available. In the process of clinical diagnosis, it is not that simple. Sometimes we might have to exclude certain other possibilities, and especially when they are not typical. Again, the classic Guillain-Barré versus the Miller-Fisher. you can see how the differential diagnosis vary. The myasthenia gravis is coming to the because even that is listed as a differential diagnosis, brainstem stroke. So Miller-Fisher, again another name, and who detected this, who actually explained in his article in way back in 1956. That is how the Miller-Fisher. Yeah. Then later on it was considered as a Guillain-Barré variant. Because staff, again, I have already explained the three features of Miller-Fisher are there and up in the line, but it really coupled up with the pyramidal signs and the impaired consciousness. These are the differential diagnoses. Commonly, the transverse myelitis, sometimes the myasthenia gravis, depending on the variant, botulism, vascular issue, pathophysiologies, carcinomas, lymphocyte, meningitis. These should be considered. And then the differential clues of the clinical features and the lab will help us in order to diagnose, and then the imaging and the CSF studies will be helpful. And these are the other differential diagnoses that they have listed. The CNS differential diagnosis, you can think about going up to inflammation, then going up to malignancies, compression of the brainstem, strokes, vitamin deficiencies have been listed. Then the anterior horn cell diseases have been considered, especially when the FAFs are abnormal on the nerve conduction studies, the nerve roots, then the peripheral nerves, neuromuscular junction issues, obviously, then the muscles and other. So obviously the differential diagnoses are listed in all territories: the brain, cerebellum, spinal cord, nerve heads, nerve, neuromuscular junction, and the muscle. These are the 7 elements I consider in my practice. So I have a clarity to see whether we are dealing with the brain, cerebellum, spine, or the brain, nerve heads, nerve, neuromuscular junction, or the muscle. Then for the management purposes, I consider the bulbar and the sphincters also had to be listed. So that is the clarity. You can see the differential diagnosis Guillain-Barré also fulfills the entire spectrum. Oh, sorry, I have been... Right. The third decision-making point is whether we are going to keep the patient in the ward or whether we are going to put to ICU. So what are the evidence in favor of that, and how we are going to document in our BHDs accordingly. So there are 4 features listed. The one thing is, if there's a rapid progression of the weakness, yes, we have to put. If there are respiratory insufficiency or respiratory compromise, then you have to put. If there are swallowing and cough reflex issues, yes, there are. That is the reason for you to put to ICU. The other most important thing is, as I told you, the most mortality is tied up with the autonomic features. That is the other reason for you to put to ICU. So there are 4 features mainly in order to. So respiratory insufficiency, autonomic issues, swallowing and the cough reflex, and the rapid progression of the disease. These are the 4 main features. So how are you going to analyze the respiratory insufficiency? So there are 8 elements that you can think of. One is, if the patient can't, he's breathless while rest or during talking, then it's a reason for you to rush to ICU or to get look for ICU. If the child is inability to talk and count 15 or up to 20, and younger the child, they might not be able to count if they don't know the numbers, then you can ask them to sing a song, or then you can ask them to tell their name, and various ways in a one breath count whether they are having respiratory insufficiency or not. The third point is, if they are using accessory muscles, you know what accessory muscles is. The breathing is done with the thoracic muscles or diaphragmatic or accessory muscles. So if the accessory muscles are being used, then again you have to think about that you are heading for disaster rather than unless you push them to ICU. Then the respiratory rate and the heart rate, if they are compensatorily going up, then again you have to suspect in the pulse oximeter, you can see them. Then the vital capacity measurements are there, but usually in the clinical practice that may be limited. All the other features are there for you to be alarmed with. If you have the abilities, you can see the arterial blood gas. So if you have the pulse oximeter fixed up, that also will give a sound evidence for you to say that you are compromising respiratory and need the ICU. And this had been all tagged together with the prognostic value in the Erasmus respiratory insufficiency score. This is not only to put to ICU, also that is a prognosticate value. This is, I think it is better that you know this, especially when you are going to document in the ICU setting and when you are going to prognosticate. The same concept had been tied up to in a score. And you, so risk factors for prolonged ventilation. Now, when you put to the ventilator, then again you wonder whether we can be able to wean off from the ventilator or not. After 1 week, if the patient can't raise his arms, then again, he will be a candidate to stay there for a long time in the ventilator. And especially, as I told you, rather than the demyelinating type, if the axonal damage subtypes are going to stay in the ventilator for a longer period than demyelinating type. And especially with regard to their long stay, the tracheostomy and other decisions had to be decided. So that is why that prognosticate importance is coming through. Fourth step, when to start treatment. So whether we are going to treat or not. Right. So inability to walk. If the child cannot walk for 10 meters independently, reason for you to start treatment. And if there's a rapid progression, as I told you, it's a reason for you to start treatment. Severe autonomic and swallowing dysfunctions and rapid and respiratory insufficiency are reason for you to start treatment. And what are you going to do with it is immunomodulatory therapy is what is available, and you can consider this treatment based on these findings. So what are the treatment options available? We'll see actually mainly two options with regard to the real aggressive treatment, that is intravenous immunoglobulin, the same dose, 0.4 grams into kilogram over 5 days. So we are giving 2 grams per kg over 5 days or 2 days or 3 days. That is the regime that you are going to adapt. Then the other technique is using the plasma exchange, where you take the plasma, filter it for all antibodies, and then you put albumin back into your plasma. So usually going for 5 sessions. So this is expensive drug, IVIG, and plasmapheresis is also expensive. Roughly the current private sector cost about 5 lakhs for plasma 1 cycle. So altogether 5 cycles will cost about 2.5 million. And IVIG 0.4 into 5 days, so it's going to be 2 grams. And the plasma exchange also, that is actually done by the transfusion medicine consultant, you need to be worried about. But we have to get the cannula in through the anesthetist team, and also make sure the pre and post assessment activities need to be known by you in order to facilitate their process of plasmapheresis. And both these techniques are equally effective. That is something you have to know. So how are going to they differentiate? Differentiation comes depending on the technical availability and risk and other things, and then the child's condition. Based on that, we have to decide whether we are going for IVIG or plasma exchange. And the problem is the currently in Sri Lankan IVIG has their limitation of action. So in the LRH, we used to go for plasmapheresis at the first line rather than IVIG. But in the international literature, they talk in more favor of IVIG due to the reasons that the plasmapheresis is very cumbersome. It's very kind of a lot of labored activities had to come through, and it's more invasive, they think, than the IVIG, and it's cost-effective IVIG most of the time. And the risk is less. So, and in the pregnancy and in children, it is much more feasible. So considering all these things, the IVIG is considered the best choice. However, it is when the IVIG doesn't work, that in our setting, we used to take plasma exchange ahead of IVIG in the current context. However, it is both are equally effective. So using both techniques together, there are lack of evidence whether they are going to have any benefit. So basically, they talk against either technique is enough. When you are going to do plasma exchange, then IVIG versus IVIG, then plasma exchange. Sometimes some clinicians, they give IVIG and then do the plasma exchange. Then you take the all IVIG out in the first cycle of plasma exchange, so other than the IVIG which had already bound. So therefore, if you are going to give both, it is better that you do the plasma exchange first, and after a few duration, you give the IVIG for that reason. Steroids, there had been any place, so antimicrobials, antiviral, if the fever is still going on, you may consider, but the steroid, they very clearly say there is no place for steroids. This IVIG machine, plasmapheresis machine is a very complicated process. No time to explain that at the moment. So step 6 is the monitoring. So what are the parameters that you are supposed to monitor? The muscle strength, the respiratory function, swallowing function, then the autonomic, especially the blood pressure, heart rate, rhythm, bladder, bowel control have to be monitored, very closely monitored. Looking for early complications, obviously this is a now physically disabled child. a patient with CNS intact. So they are choking, cardiac and other infections, deep vein thrombosis, pain, delirium, and then the psychological aspect, depression and urinary issues because they may be on a catheter, then the constipation and other the neural aspects of that might have got compromised. Then if the eyes are kept open and if they can't close the eyes, they might have corneal lacerations. Then the dietary and other support, the electrolyte imbalances, pressure ulcers, and that bedridden patients, compression of neuropathies because they don't feel with the sensory features, and limb contractions. These are early complications. So clinical progression, as you have already got to know, the treatment related, there are two things. It is monophasic disease, but I told you there can be treatment related fraction, you call it TRF. At the same time, there can be the recurrence of this in a very minor percentage. So clinical progression, insufficient response to treatment is another issue that we need to discuss. Ideally, it had to be multidisciplinary discussion. After the standard treatment, some don't respond, then what we are going to do? Actually, that is a debatable issue. A certain percentage, less than 10% is going into that, and that is a decision we have to do it at the higher level. Then the predicting outcomes, I told you, most of them come out 80%, and you have the score for you to do that. Recovery can continue for 3 years, but the most 80% will recover after 6 months of disease. Recurrence is rare. And especially the risk factors for mortality is advanced age, severe disease at the onset, and long-term residual complications. Rehabilitation, of course, physical and social, and then psychological rehabilitation. It's rehabilitation consultants should actually get involved. And the practices, there are various, say like water therapy, and them are being taken as top hierarchy. And the rehabilitation program is a multidisciplinary work. But obviously they have psychological depression, then they might have fatigue, there may be long-lasting pain, psychological distress, and especially they are conscious, but their motor deficiency is there. When you are talking at the bedside, you have to be cautious. These people are always listening, so they might later on tell you. So when you are discussing that, we should not generate anxiety within them. So we have to be very cautious. So the physical function, fatigue, pain, and psychological distress. So especially bedside manners have to be very much, because they are conscious though they can't move their body. So rehabilitation. So with regard to the Guillain-Barré, the medical documentation and parental education has a very key role. Dr. Ishanka Chaturangani, the registrar in pediatrics, is working under me. He'll basically elaborate to you on those two aspects.
Good morning, everyone. I'm Ishanka Chaturangi, pediatric registrar, working under Dr. Anuruddha Padaniya, sir. Thank you very much, sir, for giving me this opportunity. So because of, today my presentation is on medical documentation regarding a case history we have recently managing in our ward, and the parental education. So I'm discussing regarding a recently admitted patient currently managing as Guillain-Barré syndrome. The child admitted 7 days difficulty in walking. Can you hear me now? Sorry for the disturbances. And so I'll discuss about medical documentation with the help of a case history presentation and the parental education. And the case history is regarding a 9-year-old girl recently admitted to our ward, currently managing for Guillain-Barré syndrome. So for the continuation of this presentation, I have included some photographs of the BHT documents. These are just graphical representations only, not from the original document. So the patient is a 9-year-old child from Alpitia. She's a previously healthy child. Came with the progressive difficulty in walking for 5 days duration, and there was a preceding upper respiratory tract infection 3 weeks back. And this is how we got the history. So the child is a firstborn child to healthy non-consanguineous parents. And there was no antenatal or birth problems, and the development was age appropriate, and the child currently schooling at grade 4 with average school performance. And there was associated bilateral lower limb weakness and bilateral lower limb pain and back pain for 6 days. And there was no evidence of respiratory, bulbofacial, or sphincter involvement at the time of presentation to the ward. And the examination revealed the child's weight was 32 kilos, and the child was not in respiratory distress, and the hemodynamically stable. And the child's central nervous system examination revealed bilateral symmetrical weakness, more involving the lower limb when compared with the upper limbs, and there was a obvious proximal weakness than the distal level. And there's areflexia in the lower limbs and hyperreflexia in the upper limbs. And the gait assessment, the child cannot walk more than 2 to 3 steps independently, and the cranial nerve examination was normal, and there's mild sensory involvement. So when considering about the presentation and the examination findings, the child had 2 features according to the NINDS criteria. The child had progressive bilateral weakness of the arms and legs, and there were absent tender reflexes in the lower limbs. And there were some features that strongly support for the diagnosis. And there's a progressive phase, lasts from days to 4 weeks. The child presented to our ward on day 5 of the onset of the symptoms. And there's a relative symmetry of the symptoms and signs, and relatively mild sensory symptoms and signs are also noted. And muscular or radicular back or limb pain also there. And the nerve conduction studies that she has underwent after the admission revealed there's a acute inflammatory demyelinating type polyneuropathy. The features are compatible with Guillain-Barré syndrome. So we'll discuss about the management plan. As our sir discussed earlier, there's a 10-step approach for the management of Guillain-Barré syndrome. So we'll see how we have approached the child according to these 10 steps. So the first one is when to suspect Guillain-Barré syndrome. That's the child presented with rapidly progressive bilateral lower limb weakness associated with sensory deficits. And the second thing is how to diagnose Guillain-Barré syndrome. So we have seen that the child had criteria for the diagnosis of Guillain-Barré syndrome. So according to NINDS criteria, there were 2 major diagnostic criteria, and from the history and examination, we have excluded other differential diagnoses similar to this presentation. And according to the guideline, as discussed earlier, the routine laboratory tests were done. The investigation findings were within normal range, and the electrophysiologic studies revealed acute inflammatory type demyelinating polyneuropathy changes. So we have closely monitored the child to see any features of rapid progression of weakness, severe autonomic or swallowing dysfunction, or evolving respiratory distress, and these features were not there. So the fourth thing is when to start the treatment. So the child has 1 criteria to start the treatment because the child had inability to walk independently, and she can't walk more than 3 to 4 steps independently. So the criteria is inability to walk more than 10 meters. So we consider about treating the patient. So the treatment options were IVIG or plasma exchange. So currently the child had undergone 3 plasma exchange. Now the child had significant improvement. Now the child can walk independently 5 to 6 meters. And we have monitored for other vitals. We have regularly assessed the child's muscle strength, respiratory function, and the swallowing. And we look for any deterioration in autonomic function. These were not there. And with that, we are monitoring for the complications like choking, cardiac arrhythmias, infections, and DVT, and the other associated complications of Guillain-Barré syndrome. So the 8th thing is clinical assessment of clinical progression. As we are in the early stages of the treatment, the child had underwent only 3 cycles of plasmapheresis. So we are considering for monitoring for the clinical progression and predicting the outcome and the rehabilitation later once the child is discharging from the hospital and while during the hospital stay as well. And now I'll move on to the parental education. So that's the most important thing, especially in pediatric patients, because of the kids' conditions, the parents are in anxiety. So before going to do any parental education, so we have to have an appropriate setting with minimal disturbances. If the parent is willing to accompany any other relatives, So we can allow them to participate for the communication session. And first we have to introduce ourselves, and say at the same time we have to assess their level of understanding, especially their education level or occupation, to assess the ability to grab the details we are giving the patient. And we have to gather information about what they have already know about the condition. That will help us to again assess the understanding of the parents, as well as we can have some idea what to deliver the patient, and we can have an idea about their expectation. So we can allow them to ask questions for clarifications about their doubts, and we can assess how they are gathering the information with checking their understanding, what we are giving, an understanding level of the patient. And we have to give them information with simple words, with avoiding medical jargons. And these are the key points we have to consider about giving information. So the key manifestations of classic Guillain-Barré syndrome is an acute onset ascending sensory motor neuropathy. So, but the disease can present as atypical manner as well. So we have to explain them regarding the available management options and the investigations findings, especially electrophysiological studies, and the necessity of a lumbar puncture during the later course if necessary. And some patients, they can have both normal results. And we have to explain the parents regarding the necessity for regular functioning of the respiratory function. And because the respiratory failure can occur without symptoms of dyspnea. And we have to explain them about the available treatment options in Sri Lanka, especially IVIG infusion and the plasma paralysis or plasma exchange treatment. And we have to again explain them about the side effects and the especially adverse effects following medications, and we have to explain them regarding the complications and the prognosis of the disease. And the clinical improvement is usually most extensive in the first year after disease onset and can continue for more than 5 years. And we have to, in summary, we have to explain about the nature of the disease, available therapeutic options, and need of ICU care if necessary, and the outcome and the prognosis of the disease, and rehabilitation. So after delivering the information, we have to give again a summary what we have discussed with the parent, and we have to check for the understanding of the parents. And we can offer them some articles, websites, and introducing similar patients who have experienced the disease earlier. And there's a special, the websites, GBS CIDP website, we can refer them depending on their educational state. And we can arrange follow-up visits to give further information if they are willing to gather. And we can finish the communications after giving some information to the parents, and we have to give them chance to have more information from the above offered articles, websites, and if they have any clarifications, we can contact them later. So that is the end of my presentation. My friend, Dr. Ruanka, will continue the next session.
So very good morning. I'm Dr. Ruanka Delira, Pediatric Neurology Registrar at Ledridge Hospital. Thank you very much, Ishanka, and thank you very much, Dr. Padania, for giving me this great opportunity. So here, I think you all have understood well about the Guillain-Barré syndrome lecture. And for the sake of completion, I'm going to discuss few questions, some MCQs. So then after that, like we can see whether you have well understood about these topics. So here, this is a summary which I'm going to show you all. Give me a second. Right. Okay. Right. So here, okay. Right. So this is a small summary what we discussed. So this is about the clinical presentation types, investigations, and the possible common variations. And so here, when we move to the if we move to the questions, so this is the I will not take that much time. So this is the very first question. So which of the following are true regarding Guillain-Barré syndrome? So you can go through these question answers. So these are true false type question. So severe wasting of lower limbs, and stem B is extensive plantar response. C is paresthesia of lower limbs. So what are the answers? So I will give you 10 seconds. So I think it is not so difficult now after this lecture. So here you can see severe wasting of lower limbs. So you know, all I know is that Guillain-Barré syndrome is it involves the peripheral nervous system, so which usually which will lead to low motor neuron type clinical features. So wasting is one of the low motor neuron type lesion. But since this Guillain-Barré syndrome is an acute condition, so severe wasting will not usually seen during the acute manifestation. So it is not a feature, severe wasting is not a feature of Guillain-Barré syndrome. So, but after some time, you might notice some amount of wasting, but it is not severe wasting. So the answer is false. So extensor plantar response, it is very easy. So when we are checking the reflexes, so these are Guillain-Barré and low motor neuron sign, where you will notice flexion of the plantar response. So the extensor indicates the more towards upper motor neuron sign, or the involvement of the central nervous system. So the paresthesia of the lower limbs, so it's as Dr. Padeni mentioned, so the Guillain-Barré syndrome is not a pure motor, so it involves the sensory as well as the autonomic. So sensory symptoms sometimes can be the initial presentation. The pain, paresthesia, and numbness can be the initial presentation. The patients can present to you even with paresthesia. So it is true. So decrease in conductive velocity of nerves. So you all are well aware that myelin sheaths allow electrical impulses to transmit quickly as well as very effectively along the nerve cells. So when there's a damage to the myelin sheath, so the Guillain-Barré is all about the damage to the myelin sheath, Fallin and molecular mimicry, Fallin and post-infective immune-mediated reaction. So with the damage to the myelin sheath, so definitely there will be a decrease in the conductive velocity. So that is the classic picture which you will notice in Guillain-Barré syndrome when you check the nerve conduction studies. So the answer is true. So the stem B, increased polymorphonuclear cells in CSF. So we all are well aware that there will be a protein cellular dissociation. So the protein levels will be double the normal amount, and the cell count should be normal in CSF levels. So we ideally expect to have less than 10 in CSF sample. So definitely if it is more than 50, if it is highly unlikely to be Guillain-Barré syndrome. So if it is between 10 to 50 also, we need to have we need to consider about the other differential diagnoses as well. So I think so the answers are very clear. So we will move to next question. So next question is true or false regarding Guillain-Barré syndrome. So the respiratory function should assess daily with peak expiratory flow meter. So that is the first one. So CSF protein should best assess within first week. The steroids are mainstay of treatment. The bladder involvement is an early feature, and the proximal muscles are more involved than distal muscles always. So those are the 5 questions. So we'll move to the answers. So I will give you 5 seconds to go through these questions. Right. Hope you all are clear. Right. So here you can see the respiratory muscles function should be assessed daily with peak expiratory flow meter. So we all are well aware the peak expiratory flow meter is in our pediatric ward setup we frequently use, especially to monitor asthma, children with asthma. So we all are well aware peak expiratory flow meter is very useful in assessing obstructive airway disease, some conditions like asthma and other obstructive airway diseases. But the Guillain-Barré is mainly, it's a restrictive lung disease where the respiratory muscles will get weakened. So here the peak expiratory flow rate is not very useful in assessing Guillain-Barré syndrome. So here we mainly assess with the spirometry. So CSF protein should be best assessed within first week. So as we previously mentioned, so the protein levels are normal, like in 30 to 50% of the patient in first week after disease onset. So we usually recommend to assess best after 10 to 14 days. Then the sensitivity and the specificity also will get increased with time. So the accuracy will be increased. But even one of the key important messages, the normal CSF will not exclude always the Guillain-Barré syndrome, because even after 14 days, the very minute amount, about 10% of the patients can have even normal CSF. So the question number C. So steroids are the mainstay of treatment. So here the most important point is corticosteroid hasn't shown any benefit when discussing about the treatment for the Guillain-Barré syndrome. So sometimes they have shown the oral corticosteroids was shown even negative effect on outcome. So here the mainstay of treatment are IV immunoglobulin as well as the plasma pheresis. So then the D, bladder involvement is an early features. So I think during this lecture, we discussed that what are the features which are highly unlikely to be Guillain-Barré syndrome. There was a lot of features there, and the early involvement of the bladder bowel. So here, early onset of bladder bowel involvement or persistent bladder bowel involvement is a feature that casts doubt of diagnosis. So the final one, the proximal muscles are more involved than the distal muscles always. So the majority, the classic Guillain-Barré type, most of the time we will notice the proximal muscles will get more involved than the distals, or maybe both proximal and the distal muscles equally get involved. But sometimes the minority of the patients, especially with the atypical GBS, particularly with an A-man type, so we might see the distal muscles can get more involved than the proximal muscles. So it is also false. So we'll move to the next one. So it is very easy again. So which of the following are which of the following features are more suggestive of Guillain-Barré syndrome? So a marked asymmetry of sign, high CPK levels, CSF cell counts more than 50, persistent bladder bowel involvement, dysfunction, and the fever at onset. So I think we discussed previously. So there are a lot of features there. So which of the following are more suggestive? They have us. So these features, almost all these features are unlikely to be, the features are not so we will notice more in other conditions rather than in Guillain-Barré syndrome. So the marked asymmetry of signs, again, we know the classic Guillain-Barré, we will see bilateral symmetrical features. So marked asymmetry head towards the other clinical conditions like polio, and also high CPK levels. Usually we will notice in conditions like inflammatory myopathies, as well as in some congenital myopathies like Duchenne muscular dystrophies. So again, the high CSF cell count, again, more than 50. Again, you need to think about the other conditions like primary or secondary malignancies of the brain, as well as some infective conditions, as well as inflammatory conditions like radiculitis. So those things you need to consider rather than Guillain-Barré syndrome. So again, the persistent bladder bowel dysfunction headed more towards spinal cord problems rather than Guillain-Barré syndrome. So there were some features there. So these are the features that cast doubts about the Guillain-Barré syndrome. So we discussed previously. So again, as I mentioned, so these are the answers. Marked asymmetry is false. High CPK levels, again, false. CSF cell count more than 50, again, false. Persistent bladder bowel dysfunction, again, false. And the fever at onset, again, false. So last two questions. So true or false regarding Guillain-Barré syndrome? So can trigger following immunization? Campylobacter jejuni usually induce mild form. It is a cause for facial nerve palsy, and it's a pure motor disease. And Guillain-Barré syndrome is a causes type 1 respiratory failure. So if I give you a few seconds to go through these questions, it is again very easy. So we discussed previously also. So the can trigger following immunizations. The influenza is the very classic one, but some studies have shown even the rabies and OPV, oral polio, as well as the meningococcal, conjugated meningococcal vaccines also has contributed. And the influenza is the very classic one, which triggers Guillain-Barré following immunization. So the Campylobacter jejuni usually induce mild form. No, usually it will causes severe Guillain-Barré syndrome, and so we might see the child comes with a severe Guillain-Barré syndrome. When we ask in the history, so child must have developed an blood and mucus diarrhea 1 to 3 weeks prior to the onset of the Guillain-Barré syndrome. So again, it's a cause for facial nerve palsy. So the Guillain-Barré syndrome can involve the cranial nerves, and out of those cranial nerves, the facial nerve involvement is the one of the commonest, and you might notice around 50% of these patients. So it is quite common. So that is again true. So again, it is pure motor disease. So the classic Guillain-Barré, it involves the motor as well as sensory as well as the autonomic, which are again common. So causes type 1 respiratory failure, again, yes. So there will be a respiratory muscle paralysis. So there is a neuromuscular respiratory failure, and there will be an impaired elimination of the carbon dioxide So the carbon dioxide will get accumulated and you will notice the type 1 respiratory failure in VBG or ABG report. So we will move to the final or the last question. So hope you had a very clear idea about the Guillain-Barré syndrome. So again, the last question, which of the following are features of are suggestive of Guillain-Barré syndrome? So the sensory level, lability of blood pressure and heart rate, respiratory failure, hyperglycemia, and fatigability. So I will give you 3 to 5 seconds to go through these questions. Right. Again, it is very easy after this lecture. So again, you can see sensory level. So it's the hallmark feature of spinal cord lesion. So you will classically notice in spinal cord lesions conditions like transverse myelitis. And lability of blood pressure and heart rate. Yes, autonomic features are there in Guillain-Barré and it is very common. It is not uncommon. And the respiratory failure, yes, it is true. So it will cause neuromuscular respiratory failure. And the hyperglycemia. So it is not a classic feature of Guillain-Barré syndrome, but you will notice in some other neuromuscular conditions like myotonic dystrophy. So you will notice hyperglycemia. And the fatigability, again, it is false. So it is you all are well aware, it is the hallmark feature of myasthenia gravis. They get exhausted after using muscles or in the evening. So that is I think that's enough. I think we discussed enough questions. So if you have any questions, you can ask. I think I and Dr. Padini will answer to those questions.
Thank you everyone for joining in. I think we had a very interesting session followed by the 2 registrars also of Dr. Padini's presentation. We have received a few questions, but unfortunately we have time only to discuss a couple of them. So the first question I would like to bring to your attention is, what is the cutoff value of vital capacity to electively ventilate a patient with GBS?
I think we discussed in this lecture also, there is you must have heard 20-30-40 rule. So if the vital capacity is less than 20 ml per kg and the maximum inspiratory pressure is less than 30 and the maximum expiratory pressure is less than 40, then you need to consider about elective intubation.
We received another new question, doctor. The question is whether there is an indication for tricyclic antidepressant in the treatment of GBS.
It depends on the cycle because Guillain-Barré can cause so many other factors, other complications as well. So it always depends on the psychological state. So if there is any association, we can consider about starting tricyclic antidepressants. So we usually what we do is we do an psychiatric referral and then they will decide on whether it is necessary to start antidepressants or not.
Unfortunately, that's the only time we have today to discuss about GBS. I'm sure you all have a lot of follow-up questions. So I would like to invite all of you to contact us at Shri if you have any other follow-up questions so that we can forward them to Dr. Anuruddha Padania. Most of all, I would like to say thank you very much, sir, for taking your time this morning to educate all of us in the medical fraternity about this much needed and much discussed topic on GBS. And thank you very much for your team for joining us today and giving us your point of view and how to manage such a patient in the clinical situation in our clinical setup. We hope you will join us again next Sunday with another new topic. I think we need to make another clarification during our lecture. So I would like to give the floor to the registrar.
I think there was another question. So again, one of the important thing is the Guillain-Barré again it's a feature. The fatigue is one person has asked a question regarding fatigability. Yes, you will notice fatigability in Guillain-Barré syndrome. So 60 to 80% will have fatigability. But the point which I wanted to highlight is the fatigability is the hallmark, the classic feature in myasthenia gravis. But at the same time, you will notice in Guillain-Barré syndrome as well. So yes, so you need to understand there are 2 terminologies are there. So the fatigue is, you will notice fatigue in Guillain-Barré syndrome. So the fatigability you will notice in myasthenia gravis.